All right, guys. Yeah, a small technical issue. I think it is resolved now. Can you all hear me? Can you all see me? Can you all hear me? Can you all see me? A quick feedback. Am I audible? Quick feedback, guys. Am I audible? Am I visible? Can you all see me? Can you all hear me? Hi, good evening, Suresh. Good evening. Right. So yesterday we discussed about the esophageal cancer. We spoke about how do we diagnose the esophageal cancer. So today's objective would be to talk about its set of management. So we'll talk about the TNM classification. So start with the TNM classification. We'll talk about the TNM classification of the esophageal cancer. Now, as we've been learning about all our TNM classification based upon how they present to us, the same thing we are going to do it here also, so that it becomes more easy and more understandable for us. Now, as you know, the innermost layer that you have is going to be the mucosa. Surrounding the mucosa, we have the submucosa. Surrounding the submucosa, you have the inner circular muscles. And surrounding the inner circular muscles, you have the outer longitudinal muscles. We have the outer longitudinal muscles, right? So in the esophagus, we are only going to talk about until this point, because beyond this point, you have the adventitia. So I'm just going to say this happens to be the adventitia, which is going to be present across here. So this is the subset of the tissue that we're going to talk about, right? And obviously this layer which is going to be present here is going to be the mucosal cells. This is going to be the mucosal cells. This is going to be your mucosal cells, right? Now in the TNM classification, we'll start with the T stage first. Now when I say a T is going to be based upon the primary tumor. It is for the state of your primary tumor. So we have something called as TX, where a tumor cannot be assessed. A tumor cannot be assessed. We call it as TX. Then I say it is TI or T0 basically. T0, there is no evidence of primary tumor. There is no evidence of primary tumor. That is a T0. Then you have something called as TIS. Now TIS is nothing but high, we say it's carcinoma in situ, but when do you consider it to be as carcinoma in situ? We say when it is going to be having a high grade dysplasia. When it consists of a high grade dysplasia, that is considered to be TIS. Now if you have a tumor that is confined to epithelium, right? Either it's a high grade dysplasia or a malignant tumor, or a malignant tumor with integrity, with the integrity of basement membrane, integrity of the basement membrane is maintained. The integrity of the basement membrane is maintained. That means it is not invading the basement membrane. This is still called as TIS, right? Now comes our components. Okay. So let's try to assess this, right? Now you have a T1 tumor, right? So what is a T1 tumor? What is a T1 tumor? Now we say a T1 tumor can be divided into T1A and T1B, but based upon what is the extent of the involvement that we have to look across, right? So when I say a T1 tumor is basically that is going to invade the lamina propria. So rather than, okay, we'll make it very simple. I'll divide them into T1A category and the T1B category. What is T1A? What is T1B? Now T1A, if it is going to involve, if a tumor is involving the lamina propria, if it is involving the lamina propria or the muscularis mucosae. So as the mucosal surface has three layers itself, the epithelial, then you have the lamina propria and the muscularis mucosa. Okay. Now T1B is going to be if it is going to involve the submucosa. If it is involving the submucosa, right? Now, in simple words, if you see a tumor which is confined to this area, this is T1A. You see the tumor going into the submucosa. This is what we call it as T1B, as simple as that. Now, those who are not able to comprehend, for them, I'll just quickly go and label them across. This is the mucosa. This happens to be submucosa. This happens to be the inner circular muscles. We have the inner circular muscles. Then you have the outer longitudinal muscle. We have the outer longitudinal muscle. And the last one that you have is adventitia. The last one that you have is going to be adventitia. Akash noted once we enter into the abdomen, we will charter into peritoneum also. We'll talk about peritonitis in detail. Don't worry about it. Okay? Now that your T1 and T1B is now been sorted in front of you. Next, you have a T2 disease. A T2 disease is basically if it is involving the muscularis propria. If it is involving the muscularis propria. So if it is invading the muscularis propria, this is your T2 disease. This is going to be your T2 disease. T3 is going to be all the way to that of adventitia. If it invades the adventitia, if it invades the adventitia, if it invades the adventitia, this is your T2 disease. This happens to be a T1B disease. This is a T1A disease. And this will become a T3 disease. T3, it is going to go all the way to that of adventitia, right? Then you have the T4 disease, which is divided into T4A and T4B. Now, what is a T4A? That if it is going to invade, if it is involving pleura, pericardium, if it is involving pleura, pericardium, esophagus vein, it is involving the esophagus vein, diaphragm or peritoneum. This is your T4A disease. Now, what is a T4B disease? Now, when you look at the T4B disease, if it is involving the adjacent structures, example like involvement of aorta, involvement of vertebral body or trachea. That is your T4B disease, right? Ashwin, we will finish the entire surgery by December that I've been telling you since the beginning, and that is what we're going to do. Okay, December तक पूरा surgery end to end बेली में जो है we will cover it off. Clear? चल. So this is with respect to T4A and T4B. Now usually the confusion is how do you remember a T4A and a T4B? So let's try to get that as well. Now if you take this as the representation of the thorax, this happens to be the diaphragm. Just for the sake of understanding, let's say this happens to be the esophagus. And then you have the component here. Now, what are the structures that you're going to look across here, right? Now, the important structures that you need to note in general is obviously there is presence of lungs. So I'm just going to depict the lungs which are present here. Now, I'm just depicting that as pleura. Let's say this happens to be the mediastinum that is present, or the pericardium that we're going to talk about it. Just behind or the anterior to this, you have the trachea which is present. This is the orientation of the trachea that we are going to keep across. Right? Now, when you look at the T4A and T4B, let's try to understand where is the tumors extending from. So it's an esophageal cancer. It is an esophageal cancer. If it is involving, you can see if it is involving the pericardium, it is involving the pleura, it is involving the diaphragm, and you will see the vein which is going to run on the right side is going to be your azygous vein. So there's a vein that is running here, and this is your azygous vein, right? If it is involving its azygous vein, and obviously on the peritoneal reflection below the diaphragm, you have the peritoneal reflection. If this is involved, right, so which has been marked across here. So if this is involved, we call it as T4A. Okay. So T4A may remember almost everything which is on the right side is getting involved. Next, when you look at this is where you have the aorta which is running here. So this is the orientation of the aorta that you have, right? Behind the aorta, you have your vertebral body. So the vertebra is behind the aorta that you have, right? Now we say if the tumor is going to arise from the esophagus, if it is involving the trachea, aorta, or the vertebral body, if it is in the same line, this is going to be your T4B, as simple as that. Okay. So easiest way to remember, this is your T4A, and this happens to be T4B. Trachea, aorta, vertebral body in the same sequence. Okay. Now again, rather than trying to memorize it or just try to mug it up, this is the best way that you can understand and remember your T staging. Clear? Okay. So rather than try to remember it, T1A is involvement of the mucosal surfaces. T1B is involvement of submucosa. T2 is going to be muscular. T3 is adventitia. And then you have the T4A and T4B. T4A, you know how to remember it. In a T4A categorization, it is involvement of pericardium. It will going to involve the pleura. It will involve the azygous vein, diaphragm, as well as peritoneum. Whereas in T4B, it is going to involve a cross section. That is going to be trachea, aorta, and the vertebral body. Clear? Okay. So once you have known the T staging, let's go ahead with N staging of the disease, right? So when you look at the N staging, it is about the assessment of the regional lymph nodes. It is on the categorization of assessment of a regional lymph nodes. Now, in the regional lymph nodes, the assessment criteria NX, that is regional lymph node status, cannot be assessed. Regional lymph node status cannot be assessed. It cannot be assessed, that is NX. N0, there is no regional lymph node metastasis. No regional lymph node metastasis is noticed. No regional lymph node metastasis. In N1, your 1 or 2 lymph nodes are positive. In N2, 3 to 6 regional lymph nodes are positive. And N3 disease, when more than or equal to 7 regional lymph nodes are found to be positive, or found to be positive. That is your regional lymph node status. Now, obviously, M stands for metastasis. There is no big deal about it. M stands for metastasis, right? Now, in the metastasis, you have two criteria. One is going to be M0. There is no evidence of metastasis. So we have M0. M0, there is no evidence of metastasis. M1, there is presence of distant metastasis. There is presence of distant metastasis, right? So this is all in all with the context of your TNM staging. You now know how to categorize your T staging. You know what is going to be your T1 disease, what is your T2 disease, what is your T3 disease, what is your T4A and T4B. In T4A and T4B is the most important thing to remember, right? How do you remember it? We have given you a small diagrammatic representation to go along with it. Clear? Is that clear? Okay. Now you have the entire TNM classification for your esophageal cancer, right? So we'll talk about now the management. Clear? One second, guys. Okay. So talk about the management of the esophageal cancer. We get the management of the esophageal cancer. Now, see, all that you need to understand is in any malignancies, we have a two broader versions per se. We'll see whether it is a resectable or an unresectable tumor. We'll see whether it is a resectable tumor or whether it is an unresectable tumor. For a resectable tumor, I am going to go ahead and resect it. So in the resectable tumors, the logical option is going to be surgery. In an unresectable tumor, it is going to be your palliative care. So we'll discuss both of them, right? We'll discuss both of them, that what is the criteria for resectability and what is unresectable status and all that. Thank you, Raj. Good evening. Adya, can I get some water?
Okay, this water.
No, that's old water. Right. So when I say the resectable status or in the context of surgery, now there is criteria for resection, right? So for all GI resections, you have to follow the minimal margin of resection, right? So what are the minimal margins of resection? What are the minimal margins of resection in GI malignancy? So what is the minimum margin of resection in GI malignancy? That is something that you should be aware of. Thank you. Now, when we talk about the minimum margin of resection, we look at what is the margin of resection in the esophageal cancer. We have to see what is the minimum margin of resection in your stomach cancer. We look at in the small intestinal carcinoma. We look at the large intestine cancers, and we look at the rectal cancers. So two margins that you have to follow. One is going to be your proximal margin. Another one is going to be your distal margin, right? Now remember, when you talk about the proximal margin for esophageal cancer, it is 10 centimeters. Distal margin is 5 centimeters. For both stomach, as the proximal and the distal margin will be 5 centimeters. For small intestine, the proximal and the distal margin still remains as 5. For your large intestine, the proximal distal is still 5. For rectal, remember, it is very, very important that the proximal margin that you're looking at will remain at 5 centimeters, but the distal margin will be at 2 centimeters. So if you look at the entire data, there are only two sides which is going to be skewed, right? What is the two variations? Proximal margin of the esophageal cancer and the distal margin of the rectal cancer. The proximal margin of the esophageal cancer and the distal margin of the rectal cancers are the variation, but this is something that you need to follow. Now, what is this proximal distal margin that you have to obey? Now, let's say this is the any segment of the bowel that we're talking about. And let's say there's a tumor that is developed in this particular site. This is a site where the tumor is present. Now, what we're going to do is you're going to mark the extent of the tumor. This is the superior extent, and this happens to be the inferior extent, or you can say the proximal extent and the distal extent, right? So rather than say superior inferior, we said this happens to be the proximal extent of the tumor, and this is the distal extent of the tumor. So whatever you're going to remove it from the proximal extent will be called as the proximal margin. So if you remove this, this is what we call as the proximal margin, and whatever you remove it from the distal end, this is what we call as distal margin. So this is the proximal margin, and this happens to be the distal margin. This is the proximal end of the tumor. So this is the proximal end of the tumor. This is the distal end of the tumor. So when you remove the entire, the subset, you see this is the proximal margin that you're removing. This is the distal margin that you're removing it, along with the side where the tumor is present. So this is the total loss of the bowel that you have, and then you'll re-anastomose it, right? So this is the basic objective that you have to follow in all GI malignancies. What is the margin of resection that you're following, and how are we going to anastomose it? That's a basic thing that we have to follow in terms of malignancies. Okay? Now that you have understood this, right? Another thing that you need to take care into consideration in the esophageal malignancies or the management is the G-junction cancers, right? So for our G-junction malignancies, for a gastroesophageal junction malignancies, for a G-junction malignancies, how would you like to approach it? Now, the approach for G-junction malignancy is given with the help of a classification that is called as the Sievert classification. That is given by a classification that is called as the Sievert classification. It is given by a classification that is called as the Sievert classification, right? So I'll be discussing with you something very interesting, which is called as the Sievert classification. So Sievert classification is basically to classify the G-junction malignancies and how would you approach them in general, right? So when you talk about the Sievert classification, let's try to understand it this way. Now, let's say this happens to be the esophagus. This happens to be the stomach. And let's say this happens to be the gastroesophageal junction. This is the diaphragm, which we are not really interested in this particular context. Okay. Now what we do is we are going to mark the margins here. So the margin that you're going to look across here, we'll see 1 centimeter above the G junction and 2 centimeter below the G junction is the first category. This is 1 centimeter from the gastroesophageal junction. This is 2 centimeter from the gastroesophageal junction. The upper limit is set at the 5 centimeters from the gastroesophageal junction, and the lower limit is also set at 5 centimeters from the gastroesophageal junction, right? Now it says the civet has different types, right? If the tumor is present in this region, that is 1 centimeter above till the 5 centimeter part, this is what we call it as the type 1G malignancy. This is what we call as type 1G malignancy, right? Now, if it is going to be present between 1 centimeter above and 2 centimeter below, this is what we call it as the type 2G malignancy. This is what type 2G malignancy, and one that is present between 2 to 5 centimeters, which is here. This is what we call it as type 3G malignancies, right? So based upon its extent, that three different types of the G junction malignancies. Type 1 is 1 centimeter above till 5 centimeters. Type 2 is 1 centimeter above and 2 centimeter below if the tumor arises, right? So if I say if a tumor is going to be present in this region, if a tumor is present in this region, it is a type 1G malignancy. If a tumor is present here, it is type 2G malignancy. If a tumor is present here, it is a type 3G malignancy. Now, why it is important is, remember, type 1 and type 2, they are managed as esophageal cancer. They are managed as esophageal cancer. Whereas type 3 will be managed as gastric cancer. This is managed as gastric cancer, right? So that's a carry on message. Type 1, type 2, they're managed as esophageal cancer, and type 3 will be managed. Type 3 will be managed as your gastric cancers. Clear? So now you have a clarity that if you have a GE malignancies, how do you are going to address with respect to that? Now, how do you manage it stage wise, right? So stage wise management of the esophageal cancer. Stage wise management. So when you look at the stage wise management, what are the component that we have? We had a T1A disease. For a T1A disease, I would do something called as EMR, that is your endoscopic. We'll do a endoscopic mucosal resection. We'll do something called as an endoscopic mucosal resection. Now, again, it's a beautiful concept to understand that how do you do an endoscopic mucosal resection. Let's say this is the site where the tumor is present. Let's say the outermost layer that you have is the mucosa, and then you have the submucosa. Then you have the circular muscles which are present here, and under the circular muscles you have your longitudinal muscles, correct? Right? And we're seeing that our mucosal surface or the epithelial surface is here. Let's say we have a T1A disease, which we've already discussed, which is arising from here. So how do you do an endoscopic mucosal resection is, I am going to go via the endoscope and go under the mucosal surface, right? Now, after I undergo the mucosal surface, I am going to inject a fluid under the mucosal surface to elevate this area. So as I inject the fluid, it separates the mucosa from the submucosa. Now, as it separates the mucosa from the submucosa, what is going to happen? So this is fluid which is separating. You now notice that the mucosa is going to be elevated. and you see the tumor which is formed is also here. Now you got a clear plane. So what I'm going to do is I'm going to run the to a different color. Okay. I'm going to run this area and excise this. Okay. So now it is easy to excise because it is lifted up. And this is what we call it as endoscopic mucosal resection. That is for T1A disease, right? Now for a T1B disease and a T2 disease, for a T1A disease with T2 disease, if there are no lymph nodes involved with N0, then surgery alone is enough. If surgery alone is enough, right? Now, if you have a T3 disease, or if there are lymph nodes which are N1, N2, or N3, right? Now, this is what we call it as a locally advanced stage. This we would consider as locally advanced. Now, for a locally advanced disease, what do you like to do? For a locally advanced disease, I will start the patient on chemo radiation. That is, neoadjuvant chemo radiation will be given. I will wait for 4 to 6 weeks. So after 4 to 6 weeks, I would go ahead with surgery. That the principle is same. You have marginal resections has to be followed and the anastomosis has to be performed, right? Now, if it's a T4 disease or an M1 disease, if it is a T4 disease or an M1 disease, then it is considered to be as an advanced disease. So here only palliative management. Here it will be considered as an advanced disease, and here we will go ahead with palliative management. So surgery will discuss about it. In the palliative management, the basic concept is that this patient is going to have dysphagia, right? So how do you overcome this dysphagia? Is in a palliative management, one such thing that I can talk about is where a tumor is completely compressing it. Let's say there's a tumor that is completely compressing the lumen and the dysphagia is quite severe. So what you do is you're going to install a stent. The stent that you're going to put goes by the name which is called as SEMS. SEMS is self-expanding. It's a self-expanding metallic stent, and this metallic stent is usually a covered stent. So you get two stents. One, you will have a meshing. So if you have a stent which is like this, right? If you have a stent which is like this, you can see the pores here. This is uncovered. On the other hand, if you have a stent which is like this, this is called as covered one, right? So as you know, there are two different stents that you have. This is a covered stent. This is an uncovered stent. This is an uncovered stent. So what I'm going to do is I'm going to install a covered stent into this. So once I put a covered stent, once I install a covered stent, which is going to be here, it will push the tumor away, keep the lumen patent. It is pushing the tumor away. It is pushing the tumor away, keep the lumen patent, and allow the passage of food without any problem. Okay, we have a question. Raj, we give the chemo radiation to debulk the tumor so that we get good amount of margins and obviously symptomatic relief also. Okay, and also we see whether the tumor is responding to chemo radiation or not to know whether it's a responsive or a non-responsive disease, right? Now, in terms of surgery, now when you have esophageal surgeries, or I can say for the surgical techniques for esophageal cancer, when you have a surgical technique for esophageal cancer, when you look at the surgical technique for the esophageal cancer, we have three basic techniques. Number one is your Ivor-Lewis surgery. Another one is your McKeown surgery. And another one is your Oringus. So let's try to understand what is the difference between these three techniques. What is an Ivor-Lewis surgery or a Ivor-Lewis technique? What is your McKeown's technique? And what is going to be your Oringus technique? Right? So when you talk about Ivor-Lewis, remember Ivor-Lewis is a two-phase surgery. McKeown's is a three-phase surgery. Oringus is again a two-phase surgery. What do you mean by this? Now, if you take this as a representation of the neck, let's say this is a representation of the neck. This happens to be the thorax, and let's say this happens to be the abdomen. This is the status of the abdomen that we have. This is the suprasternal notch, and this happens to be the sternum. Right? Now, this is the orientation that you're going to keep across it. We'll use it for all three components. So when I say there are three phases, let's see all the three phases. Now in Ivor-Lewis, there are two phases. That means I have to remove the esophagus, right? In order to remove the esophagus, where would you like to put the incision, right? So one, obviously, just for the sake of understanding, so that you don't get confused, this happens to be the right, this happens to be the left, this is the right, this is the left, this is the right, this is the left. What happened? 1 second, guys. Do you want to stand here? Okay. Now, when I say an Ivor-Lewis surgery, Ivor-Lewis is a two-phase surgery. I have to remove the esophagus, right? How do you remove the esophagus? Like, what are the approaches that you can have? This is the umbilicus, just for the sake of understanding, right? Now, one, you can take an approach here by this, that is right-sided posterolateral thoracotomy, and then you also perform a laparotomy, right? We have two incisions that you have. One is going to be a right thoracotomy, another is laparotomy, and you try to remove the esophagus. In a three-phase, I do a right thoracotomy, I will do a laparotomy, and I will also do a left-sided cervical incision, that is the neck incision. The most painful of all is thoracotomy. So in Oringus, we are doing only the left incision, which is in the neck, and then you're doing a laparotomy in the midline. Okay, so this is what your Oringus surgery is. So what are the Ivor-Lewis? What are the two incisions that you have? Now, one, you have the right thoracotomy. Another one that you had is your laparotomy. In three-phase, you have the right thoracotomy. You are doing laparotomy. And then you're doing a left cervical incision. In Oringus, you're doing only the left cervical incision and you're performing a laparotomy. Now, because there is no thoracic incision in Oringus, Oringus is also called as transhiatal esophagectomy. It is your transhiatal esophagectomy is performed. But Allen's test will tell you about the patency of the palmar arches, and if you have a AV fistula in the forearm, that is mandatory to do it to confirm whether the contralateral segment is patent, so that you don't need to ligate the vessel. Okay. Okay. Now, once you have decided what incisions to place, you have Ivor-Lewis, McKeown's, and Oringus. Based upon that, you are now going to get inside. Now, ultimately, what is going to happen? Let's try to understand that as well. You have the esophagus, and you have the stomach, which is in continuous with the duodenum. I am saying that there is a tumor that is present inside the esophagus, and we have decided to go with a proximal 10 centimeter margin and a distal 5 centimeter margin. it's a 10 centimeter proximal margin and a 5 centimeter distal margin. So this much amount of esophagus is going to be sacrificed. So we're going to remove this entire esophagus per se. This much amount of esophagus is gone. Now, as this much amount of esophagus is gone, you have to reconstruct it back. Now, how would you reconstruct this part of the esophagus? Now, I have this part of the esophagus which is lost, and you have distal esophagus, and then the rest of the stomach is present. So, what you do is, with the help of the endo GI stapler, I'm going to divide the stomach in the form of a conduit, and this is how I'm going to mobilize the stomach. So this is my staple line, and this is how we are going to divide the stomach, right? So I will basically staple this off, and the stomach is removed. Are they okay? Right. Now once you fire the staples, now you can see that it is now creating a new gastric conduit. Now this is what we call it as creating a gastric conduit, right? Now this part is what we call it as the gastric conduit. Now when you construct the gastric conduit, you've put the staple, you've divided it. Now I will pull this part up. Now as I pull this part up, what is going to happen? This part of the esophagus is still here. This part of the esophagus is now pulled along with the stomach. Now this is the gastric conduit that you have pulled, which is continuous with its rest of the segment, and then it is continuous with the duodenum as well. So if you see it very carefully, this is the stapled end of the stomach. This is the staple end of the stomach that you have pulled it across, right? Now this part we have pulled it across, and now eventually when you reach across here, I am now going to make an anastomosis, right? This is what we call it as a gastric conduit anastomosis. So you have mobilized it, and now you have created it, and this is how you will do a esophageal reconstruction. This is what we call it as an esophageal reconstruction, and by using a gastric conduit. There is no if, there is no but in this. If you understand this, that is more than enough. See, in children, you can use jejunum or a left-sided colon as a transpositioning surgery, but gastric conduits are usually preferred. Is that clear? Is that clear? Right. Now, we also said that we will give you chemo radiation. What is the chemo reagent that you can use here? Now, the chemo reagent that we usually use for esophageal cancers is what we call it as an ECF regime. E stands for what? Epirubicin. C stands for what? It's a chemo reagent, that is your cisplatin. And F stands for what? 5-fluorouracil. Okay. And this is how you deal your patients of esophageal cancer, right? So this concludes our entire discussion on esophagus. We have completed every single topic that is available, starting from the basic anatomy to that of malignancy. Every single thing that is there in Bailey, we have concluded it, right? So this concludes the discussion on the esophagus, right? So the next session, stay tuned. We will come back with stomach. Again, a very, very interesting topic. So tomorrow we'll have a basic surgical anatomy of stomach and its orientation of physiology. And then we'll talk about the other disorders of the stomach that are important, right? Thank you so much for joining today. We'll resume back tomorrow again. And tomorrow we'll start with the surgical anatomy of the stomach. Thank you guys. Take care. Bye.
It's recorded.
No, it's live. You can say bye. Say bye bye.
Bye.
Bye guys. Good night. Take care. Right. Keep reading. Oh, we forgot. Where will you get these notes?
What?
If my students wants to get these notes, no. So where can they find it? They can find it in this group. No, what is this group?
The surgery guy.
Yeah. Right. So they can find the notes in the surgery guy, and it is by my name. No, what is my name? Dr. Sandeep. Yay. Right. So thank you so much guys for joining today. We'll see you guys tomorrow. Thank you guys. Take care. Bye bye. Adi, say bye. Say bye.
Bye.
Good night.
Good night.
Okay.
Hmm.